Hello everybody, I am about to be joined live by the director and founder of Wijnland Fertility Clinic in South Africa, and we're going to discuss blastocysts, so hatching blastocysts, and whether that means that it improves IVF success, whether it's something that you should be looking out for, asking your clinic, thinking about as you prepare for IVF. So have your questions ready. I'm being joined by their founder and director, medical director, Dr Johannes Van Waart, and I'm just going to invite him in now. Bear with me. Hi everyone who's joining. Nice to see you today. Just be joining any second. Have your questions ready for the founder and director of Wijnland Fertility Clinic, Dr Johannes Van Waart, who will be answering them on hatching blastocysts, everything you want to know about blastocysts and whether that improves IVF outcomes. So still trying to connect. Just bear with me for a second. Should be here any second. Sorry about this. Okay, if they don't connect in a second, I will go off and come back on once we've spoken. There we go. Hello, good afternoon. Nice to meet you.
Hello, Eloise. How are you?
I'm very well, thank you. How is everything in South Africa?
Oh, it's pretty summerish here with a temperature of about 38 degrees Celsius at 7 o'clock in South Africa, so we're in the middle of summer.
Oh, how delightful. That is very different to where we are in the UK right now, that's for sure. But I've just introduced you briefly. Could you tell us a little bit more about yourself and Wijnland Fertility Clinic, and then we can start talking about blastocysts and hatching blastocysts?
Yes, my name is Johannes Van Waart. I'm one of the founders and the clinical director at Wijnland Fertility at Stellenbosch in South Africa. So I am an obstetrician, gynecologist, and a fertility specialist. And we've had our unit now for the last 15 years. So we operate from Stellenbosch, which is about 50 kilometers from Cape Town in the Wijnlands of South Africa.
Amazing. And blastocysts, this is a question that we get asked a lot about. And you've just written a fantastic article with us, which everyone should read. So as well as watching this, please go and read it because it answers all of our reader questions. And Wijnland Fertility Clinic have answered them. So head to the link in bio to read those. First question I'm going to ask you whilst we're live is, what is a hatching blastocyst for people who aren't sure?
I think first we need to actually just explain what a blastocyst is.
Yes, true.
So normally, once the genetic material are put together, the sperm and the egg, then a certain process needs to take place. Now, normally fertilization takes place, and that you can see normally after a few hours of putting the genetic material together. Then normally on the first day after the fertilization, you will see the little blastocyst or the embryo actually starting off into 2-cell stage. Then on day 2, it will go on to 4-cell stage. Then day 3, it will go on to 8-cell stage. And then on day 4, it will make a little blob, which we call actually just compact. And then it will differentiate into a part which we call the trophectoderm or the placenta, and the inner cell mass that actually forms a little baby. Now, that blastocyst on day 5, we grade on a scale of 0 to 5 in terms of expansion. 1 just being sort of slightly expanded, 5 being maximally expanded. And then we also grade the inner cell mass and the trophectoderm from A to C. Now, once it goes past the 5 expansion, then the little shell called the zona pellucida actually perforates, and part of this little embryo actually creeps through that hole. And that process where the little embryo comes from the shell, we call hatching. And that's a further development, and there are timelines that we would normally actually correlate that with. And if still in a sort of incubator and it starts hatching, it means it's a really good sign and it's ready to start implantation once transfer is done.
So is there a higher success rate of IVF cycles with blastocysts which have started hatching?
I think there was a little bit of evidence to say that it actually is a good prognostic sign, But now I think in the bigger picture, it doesn't really make a big difference because all blastocysts have to hatch at some point in time, whether it's outside in the laboratory or whether it's inside of the uterus. The only problem if you transfer a hatching blastocyst, it's actually a little bit more sticky, and sometimes transferring it through a small little tube into the uterus can be problematic if the hatching has gone actually too far at that point.
Interesting. And how does it work in terms of PGS and screening on blastocysts, which are quite advanced? Is it dangerous to do that with them, or is it still okay?
Yeah, I think PGS is an older term, which could stand for pre-genetic implantation screening. I think nowadays we talk about PGT, pre-implantation genetic testing, and then you can either do an A, which means for aneuploidy, just to test in general whether it's normal, or you can also do, if you test for single genes, you can call it PGT-M. Now, in order to take a little biopsy from the trophectodermal little placental part, you actually need to get to that tissue. So if the embryo allows you to do that on its own by hatching, I think it's a little bit less invasive. Otherwise, what one has to do is actually thin the little shell around it, the zona pellucida, by different methods, of which probably the most effective method is by using a very sensitive laser just to thin that. And once that layer around the embryo gets very thin, then it will start hatching, and then you can actually remove from 3 to 5 cells from the placental part. We would never biopsy actually the embryo itself, normally the placental part, but from a hatching blastocyst, that is probably a little bit less invasive.
Okay, so people shouldn't be afraid if that's suggested to them, or if they want to ask their specialist whether that's something that they would advise.
Yes, no, certainly. I think once you have a blastocyst and a hatching blastocyst, it's a little tricky, but it makes some part of the process a little bit easier.
Yeah. We've had some questions come in, so do you mind if I just answer these live? And then we'll move to the other ones. Is it worth paying for assisted hatching?
I think there's definitely some sort of disposables to do that, but I think if it's done for the right indication, I think definitely it shouldn't be too expensive, but it's worthwhile to pay for that. But I think with the guidance of the fertility specialist, it should be done for the right indication and not just as a request, because it's not going to change the game at all for people who are not indicated to have assisted hatching.
Okay, that's good to know. And this is a good question. You just mentioned that it could potentially get stuck during transfer if it's sticky. So would you know, as a fertility specialist, when doing the transfer, if that had happened or not?
Yes, you will definitely know. I think it's part of what we do, is if you do transfer the embryo, after you've transferred it, you can actually see visually on the ultrasound scan the little white dot, but that's normally the little bubble that surrounds the embryo if you transfer. But as a second line, what you will do is you will afterwards go and flush that little catheter in the lab and see whether that embryo is actually still stuck to the tip of the catheter. So you will definitely know if it's not there.
And if it is stuck, can it still be recovered?
Yes, I think one can then probably try to smoothen up the surface by pulling in a little bit of extra of the medium that we culture that in. And then very often what you'll do is you'll just put a little extra pressure on the little syringe that we use to dispose and get the embryo into the uterine cavity.
Wow, this is absolutely fascinating. I'm learning so much today. Thank you. I'm sure everyone else is who's watching. Someone said their last hatching, it was an embryo grade 5BA. It didn't survive the thaw. Do you know what is normally the cause for embryos to not expand? Why do some of them stop growing?
I think there are a number of reasons they can stop growing. I think it's not a question that they will develop quite sort of normally right to the end and then just stop. It will normally give you some indications. And normally the first 3 days of the embryo development is driven by the genetics of the egg. So if it comes to day 3 and it's a nice 8, 9 or 10 cell embryo with a good grading, then normally the sperm starts dominating after that. So it's very unlikely that it will not survive the thawing if you have a good freezing program, if it gets to a very good stage at the end with normal timelines. And we have timelines that we know that they should develop by.
Mm-hmm.
So if it slows down at the latter part of the development, and that's very often what happens, it's most often the sperm that was selected that probably wasn't as good as we would like it to have, but you will in most cases get some kind of indication why it slows down and then stop developing. It's not a clean process and boom, all of a sudden it stops. There will be some indicators, and that will guide us in terms of selection of embryos and also in terms of guiding the couple after the transfer or not survival on what to do next.
Okay, thank you so much. Do you tend to see lots of patients from around the world?
Yes, we see a number of the patients. Most of our patients are locally, I think from South Africa, but we do see about 10 to 15% of the patients that we do see coming from all over the world. It's been a little bit less now with the COVID and travel restrictions, but we deal with overseas patients quite frequently.
Mm-hmm. And if people were interested in coming to see you or have a consultation with you, can they do that virtually first?
Yes, I think what they would normally do is they would log into our website and there's a questionnaire that they would answer.
Okay.
And then what we would do, once we have that information, if we need anything else, we'll ask for that. And normally what they will do is then we'll, via Skype or via Google Teams, we will have an interview with them just to make sure that they have all the information that they need. We will propose a plan. We need all the information that they can provide us. And then very often the patients come to South Africa, and then we see them here and we treat them and with good success.
Fantastic. Well, for anyone who's interested in speaking to Dr. Johannes, then as I said, the link is in the bio to read this fantastic article, which goes into more detail about blastocysts and what we're discussing today, and the contact details are in that. The next question, does a hatching blastocyst, would you say that it is a good sign? Is that something that if someone is handed an embryo card going into transfer, they should be happy to see? Is it something that if they don't see, they should be worried that it hasn't hatched or started hatching?
Yeah, I think there's a little bit of context behind that. I think hatching blastocysts is always a good sign as long as it doesn't hatch too early.
Okay.
So we have normal timelines, and I think the advantage that we have is we have what we call an embryoscope or time-lapse machine. You can actually take a little picture of the embryo every 15 minutes. And in order to get to day 4 or the compact stage, that has to happen between 68 and 90 hours. Now, sometimes those embryos can run away and they will compact at 59 hours or 60 hours, and that's not a great sign. So they will tend to hatch a little bit earlier, but I think the prognosis for that embryo is definitely less than when it sticks to the normal timeline. So in general, hatching blastocyst is a good sign. If it hatches too early, it's something that we're a little bit concerned about, but certainly doesn't mean it cannot implant and not give you a baby, but you must see that in context.
Mm-hmm. Do you like to push embryos to blastocyst stage? Someone asked about whether if they have low AMH and they don't have many embryos, is that something that you would try and get to?
I think in our clinic, mostly we try to go to day 5 because we have a policy of single embryo transfer, which I think is the golden standard around the world. And the reason why I would push them, because if it does work, nobody really cares how it worked, as long as it works and it gives you a baby. But if it doesn't work, very often we get a lot of information from that, in the sense that if it slows down and it develops nicely to day 3 and it slows down, we certainly know that there's a sperm parameter or a sperm factor to that, and we can make certain conclusions from that to help them on the way forward. So there are units that actually put back day 3 embryos, and it's certainly not wrong, but some of those embryos might run really well up to day 3 and then slow down, where some of them actually can correct themselves because a good sperm can actually help an average egg to get to a very good blastocyst, and you might be transferring the one that is not as good in the end. So we tend to push our embryos to day 5, and the reason is we get a lot of extra information from that. A good embryo can sometimes overcome some very, very big hurdles where an average embryo sometimes struggle. You have to treat them very carefully.
Okay. I have twins from an embryo transfer of 2 embryos, and when I show my twins the picture of them as embryos, one is a lot more advanced than the other, so one is a lot bigger than the other in the picture, and they always fight about who's the bigger embryo.
Yes, but as in life, it's not always the top performers in the class that get the furthest. I think a lot of the big success stories in the world are people who were very, very sort of average at school and at university or in further education. But when they found their niche market, they really took the full opportunity and they developed. And I think in embryo terms, it's also like that. You'll sometimes see a very good embryo who would not give you a pregnancy, and sometimes a very average and even a poor embryo that will fight its way through and give you a very healthy baby. And I think one has to be careful just to sort of generalize and far as that. So sometimes it's the one that lags behind that has more energy and actually is determined to get there and actually comes further.
Because someone has just said, so I guess they want reassurance that they shouldn't be concerned if it isn't hatching at the time of transfer, if it's thought of as high quality. They said that they used hatching because they did assisted hatching, because they did PGT.
Yeah, I think assisted hatching is something that's a good sign, as I said before, but probably in our unit, probably 99% of the transfer we do with non-hatching embryos, because we have a very, very good track record of every embryo where we take a picture every 15 minutes from that embryo. So, we know it from our success rates, it doesn't really make a big difference. If you had assisted hatching for the reason of doing PGTA, then certainly your embryo will be hatching. And in that case, you must just make sure it doesn't stick to the tip of the catheter. And if it's normal, I think the chances of actually kicking in, I think, and giving you a baby is very good.
Okay, that's really good to hear. Thank you. And do you see a lot more success with embryos that have PGT? Are your success rates high after pre-genetic testing?
No, I think that's it sounds very logical to say if you only transfer normal embryos that their chances will be better, but we know from the international big studies that it's certainly not so. In actual fact, what you do is you take away a little part of that embryo or from the placenta, and if it's not strong enough to overcome that, you can actually cause harm. It's like just cutting off your finger just to try to make a diagnosis. You're never perfect after that. You can cope with that. And sometimes the embryo, in most cases, will correct itself. But potentially, it can also cause harm, depending on a number of factors. So I think to do PGTA, I think is not something that should be advised for everybody. Okay. Sometimes you get a result that you don't want. So you get a mosaic embryo that will probably or could give you a normal baby, but you won't transfer it. So you will sometimes stop an embryo that will give you a normal baby from transferring just because there was something small that was bothering. So I think one has to be careful just to do PGTA. And I think around the world, PGTA on a regular basis is certainly not something that should be done.
Really interesting. Have you seen that before where mosaic embryos have ended up having, becoming a baby?
Yes, of course. I think there's lots of literature to support that, but that's a very careful decision that should be made by the clinician and a geneticist to make sure that that you put back the right embryo. And if there's a mosaic part to that, it depends on what is the mosaic part that's there and also the fraction or the percentage of that's involved.
Okay. Do you see more success with Blastocysts in terms of implantation rates than you do with, say, day 2 or day 3 embryos?
Yes, definitely. We see it. It's significantly more because it makes the selection of the good embryo just so much easier. And if you have an embryo that's developing well with good energy and good parameters, certainly the chance of implantation and give you a normal baby is more.
You must have seen that dramatically increase over the last 20 years.
Yes, no, certainly. I think the first thing that happens, and the reason why we actually went to single embryo transferred about 10 years ago, is because I also do obstetrics. And if you transfer 2 embryos, which was usual practice for us until a number of years ago, we see a lot of twinning. And unfortunately, not all twin pregnancies come out well. So I've done delivery of twins after IVF at 24 weeks. Now, we've also seen them that they come out at 26 weeks. And I think the chances have some kind of a problem with that is quite big. And because we've worked with those parents along the way, did the IVF, did the delivery, sometimes it makes you really feel guilty because you know the prognosis of those 2 babies that come very early are not as good as if they were full term.
Do you get lots of patients asking you if they can have a double embryo transfer?
Yes, we do see that. We see quite a number of patients from Africa, and I think in Africa the culture is very much so. If you have twins, you are really the queen of that town. So you get that, but what you must remember with that, if you do the transfer, it doesn't double your chances of falling pregnant. Actually, if you take cumulative rates and you put back two good embryos consecutively in cycles, your chance of success is approximately 20% better than if you put them back together. If you put them back together, good embryos, just your twinning rate is much more. So you get about a 10. So if you have a 60% chance of success with a single embryo, and you put back two embryos, it'll probably go up to around 67, 68%. So you'll get 8% better chance. If you put them back consecutively, then you get a 60% chance with the first one. The second one still has a 60% chance, but 40% of those patients are not pregnant. Now you put back the second embryo and 60% of them will fall pregnant. So you'll get to 84%. So you compare 84% chance of success with a 68% chance of success. It's significantly more to transfer them consecutively and not putting them back together.
That's incredible, isn't it? Because I think that there are so many people in the community, myself included, who assumed that two would mean a higher success rate. So if two are transferred at the same time, how can it lower the success rate? Is it that they might sort of compete with each other whilst implanting?
Yes, I think the jury is still out with that, but certainly there was a concept that we used to call embryo crosstalk. So the good embryos actually talk to the bad embryos and vice versa. So if you put back a really good embryo and you also put back a poor embryo, the body very often reacts on the impulses of the poorer embryo. So you might actually pull the good man down, and that happens in life as well. So if you have a naughty class and you really have a good person in there or good student, then very often they'll fall back and also join the habits of the poorer students. And although there's not a lot of evidence at the moment that support that, if you have the choice, I would rather go for the single embryo transfer and give each and every embryo their full potential chance of actually succeeding.
I love this. It's such useful advice. Thank you so much. I'm sure everyone is finding this very, very useful. Is there anything else you think people should know around IVF, blastocysts?
I think in our game, it's a game of precision. So one must actually give a lot of attention to small details. Now, the best that we can do is to make sure that everything we do as good as we can. And obviously from the patient side, they must do everything as good as they can. We're responsible to help them to do from the stimulation part and also from the medication part as good as they can. But unfortunately, there's still a big part that's outside of what we can do. And sometimes we see that patients, if you don't explain that to them carefully, they think if they don't fall pregnant somewhere, the unit is messed up or somebody has messed up. And that's not right. So remember that even you get to blastocyst stage, you see that embryo for the first 15 meters of the 100 meters. And it's not always the guy that's in front at 15 meters that's going to win the race. It depends on individual potential. Sometimes embryo are really sturdy. They can correct themselves. If they have enough energy, they will go the way. So in most cases, if an embryo doesn't succeed, it's because something inside there is something not perfect. And we don't know exactly what it is, but that's why the science of fertility is so fascinating to try and figure that out.
Amazing. This is super useful. Thank you so much. For anyone who has just joined, as I mentioned before, if you head to the link in our bio, you will find a very informative Q&A from Wijnland Fertility Clinic in South Africa, who have answered all of our reader questions around blastocysts, hatching blastocysts, everything that you want to know. So please head there and read it. And you can also find the contact details to get in touch with Dr. Johannes and the team, who would be very happy to help you and answer your questions personally if you'd like to have a consult with them. Do you have time for one more question?
Yes, of course.
Do you, two. One is, at what point when you've been working with a patient would you suggest that they perhaps may not want to do any more or may not have the stamina to do any more rounds of IVF?
I think what we would do is, because we can really analyze our cycles quite well, because we know how the embryo should develop and how they should look at the end, we can actually guide the patients and show them with a little picture or a little video how the embryos struggle to get to the end. And that is quite clear to see that that embryo, if it doesn't work, it's really tried its best, but it's not to be. It's very seldom that with very good blastocysts, after 2 or 3 cycles, that you wouldn't fall pregnant. However, if there are any underlying issues, we will be very frank, and I think most of the people at our unit are very diplomatic, but we're also very, very honest. We would say to them, I think there's a really clear sperm factor involved, in which case they need some extra test, or even sometimes need to adopt sperm. And the similar for the eggs is, if you really see those eggs are struggling and we've gone through 1 or 2 cycles or more cycles, we'll have pretty good evidence to guide them to say, listen, if you really want a family, one should consider adopting eggs. But I think we get a lot of information, and we have personal talks with the patients that don't have success, taking all that information, sharing with them, and then very often we get to a good sort of decision at the end.
Yeah, I think that's great advice. Thank you so much. I've seen more questions come in, but I know you're a very busy man, so I appreciate your time. I would suggest that if anyone has any questions or would like to consult with the team or with Dr. Johannes, then please follow the link in our bio or DM them directly, and they would be very happy to arrange a consultation. So thank you so much for your time today, and thank you to everyone who joined. It's been absolutely insightful and educational.
Thank you, Eloise. It was a pleasure joining you.
Thank you. Bye-bye, everyone. Bye-bye.
Okay. Bye.